Hello, my name is Jorge Cortes, and I'm here to discuss how these new data or these long-term follow-up data with olutasidenib in patients with IDH1-mutated acute myeloid leukemia and refractory relapsed, how does it impact the care and how does it incorporate into our treatment algorithms? And just as a background, olutasidenib is a new IDH1 inhibitor, and it has some unique non-clinical properties that may be attractive. For example, it has a very tight binding to the IDH1 mutation. It is very specific against the mutated. Some of the other inhibitors may bind to the non-mutated IDH1. It also binds even in the presence of co-mutations in IDH1 that may confer resistance to other inhibitors, and it has a better binding ability compared to some of the other available, whether commercial or investigational drugs. So it has these properties that make it very attractive. And this study was part of a very comprehensive development strategy for olutasidenib that included some monotherapy cohorts and some combination cohorts, some refractory relapse, some post-transplant, some newly diagnosed. But specifically the data that we're talking about today is for the patients in the pivotal cohort, the refractory relapse acute myeloid leukemia with IDH1 mutation. And this cohort included 153 patients. And they were treated with what is now the standard dose, 150 milligrams twice daily orally. And the primary endpoint of this study was a combined CR plus CRh. And of course, there were secondary endpoints in many ways. And this was an older patient population. 71 was the median age. And these patients had about a third had secondary AML. They were largely, 80% were either refractory or had a short remission duration of less than 12 months. The majority of them had received a cytarabine-containing regimen, so mostly they had received more intensive therapy. And the results really with this long-term follow-up haven't changed. The primary endpoint, as I mentioned, CR/CRh, was achieved in 35%. But one of the things that stands out with this drug is the fact that it was a CR in 32% of the patients. So overwhelmingly, the responses were CRs more than CRhs. There were, of course, a few other CRIs and partial remissions. So if you add all of that, then the overall response rate is 48%. But again, the primary endpoint was the CR/CRh. What is very important in this long-term follow-up is the duration of the response. These responses have been very durable by of all the responders, of all the patients that achieved the CR or CRh, 2/3 maintained the response for at least 12 months. 50% maintained the response for at least 18 months. And actually, by 3 to 4 years, 48% of patients were still maintaining the remission. There's a nice tail there on the remission duration, just short of 50%, which is very encouraging because it shows that these responses can be maintained for a very long period of time in these patients. We also saw transfusion independence, which was also durable. It happens a lot more, almost universally, in patients that have a CR or a CRh. But it is also good to see that we saw responses, transfusion independence, in patients that had other responses. About 40 to 50% of patients with other responses, CRIs and MLFSs, had transfusion independence, and even about 20% of patients with no response by the hematological criteria did have transfusion independence. The other thing that's important to emphasize with the long-term follow-up is the overall survival. This has not yet been reached for the patients that achieved a CR or a CRh. So that is very good. For the overall population, the median survival is about 12 months. And for the responses, for all the responders, it was 31 months. But again, for the CR/CRh patients, this has not been reached. The median survival has not been reached. So it's sitting at about 52% by 4 years. So also very encouraging in this regard. Importantly, some patients did get a transplant. 16 patients had a transplant, 12 of them in a CR/CRh. And of course, that has helped many of the patients. And also important to note that some patients had received the venetoclax prior to olutasidenib, and 12 patients were in that category. And the responses seem to be similar, as well as the remission duration for those patients that had previously received venetoclax, which is important because many patients actually still are treated with venetoclax as initial therapy. In terms of adverse events, nothing new with this long-term follow-up. Of course, no new differentiation syndrome. We continue not seeing hardly any QTc prolongation. Definitely no more after the second year. And there was only one instance of a liver toxicity that occurred after 3 years. There was a patient that had liver steatosis. But for the most part, all the events of special interest and in general occur early on. So I think that this long-term follow-up brings a new alternative for patients that offers the possibility of CRs that are very durable in a significant number of patients. About a third of the patients have CRs, and these remission can be very long-lasting, more than 3-4 years in at least half of these patients. So that is very important. It's something that should be considered when a patient has a refractory relapse AML with IDH1 mutation. Now, how does this play with other options, ivosidenib in particular, which is also commercially available, also a very good drug? The ultimate answer would come from a randomized trial, which we don't have. These remissions seem to be higher and longer lasting, so that is encouraging, and that makes the availability of olutasidenib a very important addition to the armamentarium, and it's one that I frequently use for my patients in this context. So very encouraging long-term data with very durable remissions, very good overall survival, and minimal toxicity after long-term follow-up with olutasidenib. So thank you for your attention.